Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. Imagine a 68-year-old patient with atrial fibrillation. She's been stable on warfarin for years. Her INR is perfectly controlled. Then, she developed some nagging knee pain. The patient took a few ibuprofen from her medicine cabinet, just a common over-the-counter fix, and didn't think twice about it. 3 days later, she's in the ER with a life-threatening GI bleed. This isn't a rare fluke. The warfarin-NSAID interaction is one of the most dangerous and preventable drug interactions in medicine. And to understand why this happens, we can't just memorize that NSAIDs increase bleeding risk. We need to go deeper. So today, we're going mechanistic. Before we talk about what goes wrong, let's quickly recap what's supposed to go right when you bleed. Your body stops a bleed in 2 overlapping phases. You injure a blood vessel. The subendothelial collagen gets exposed. Platelets rush in, stick to the site, get activated, and pile on top of each other, forming what we call the platelet plug. Think of it as a soft, temporary cork. It's quick, but fragile. It won't hold under pressure. To make that cork permanent, your body triggers the coagulation cascade. This is a sophisticated relay race of clotting factors, culminating in the conversion of fibrinogen into fibrin. Fibrin is a tough, mesh-like protein that wraps around the platelets and locks the clot in place. Both phases are essential. Knock out either one, and your ability to stop bleeding is seriously compromised. Knock out both? That's a disaster. Now, where do our 2 drugs act? Exactly here. On both phases. And that's why this combination is so dangerous. Warfarin is one of the most prescribed anticoagulants in the world. It's used for atrial fibrillation, deep vein thrombosis, pulmonary embolism, and mechanical heart valves. Its job is to reduce the ability of blood to clot. Therapeutically, on purpose. So how does it do it? Warfarin targets an enzyme in the liver called vitamin K epoxide reductase, or VKOR. Normally, your liver needs active vitamin K to produce several critical clotting factors, specifically factors 2, 7, 9, and 10. Think of vitamin K as the fuel for the factory. VKOR is the recycling plant that keeps that fuel coming. Warfarin blocks VKOR, shutting down the recycling plant. The cycle stalls. And active vitamin K depletes. Without recycled vitamin K, your liver produces ghost clotting factors. They're in your blood, but they're broken. They can't bind, they can't activate, and they can't build that fibrin mesh. The coagulation cascade is dramatically slowed. This is exactly what we want therapeutically. But it means your secondary hemostasis is already weakened before any NSAID enters the picture. But here's the catch: warfarin is a high-stakes drug. The therapeutic window is incredibly narrow. Because its effects are influenced by genetics, diet, and other meds, the balance is always shifting. Even a tiny change, like a new supplement or a different meal, can tip a patient from protected into dangerously anticoagulated. That is the fragile state our patient is in before the NSAID even leaves the bottle. Now let's talk about NSAIDs, or nonsteroidal anti-inflammatory drugs. Ibuprofen, naproxen, diclofenac, or aspirin in high doses. Over the counter, widely available, and most people don't think twice about taking them. But NSAIDs are pharmacologically loaded. Their primary target is to block COX, or cyclooxygenase, an enzyme that converts arachidonic acid into prostaglandins and thromboxanes. There are 2 isoforms. COX-1. This is constitutively expressed and present in the stomach, kidneys, and platelets. And COX-2. It is inducible and primarily expressed at sites of inflammation. When you take an NSAID, it inhibits COX. And here's where it gets relevant to bleeding. Platelets express COX-1, which they use to produce thromboxane A2, a potent activator of platelet aggregation. Thromboxane A2, or TXA2, tells other platelets to pile on, amplifying clot formation. NSAIDs block COX-1, so TXA2 production drops. As a result, platelets can't stick together effectively. Your phase 1 plug, that temporary cork, is now weak and crumbly. COX-1 also creates prostaglandins, specifically PGE2 and PGI2, that protect your stomach lining. They stimulate mucus secretion, promote bicarbonate production, and maintain mucosal blood flow. These act as a shield against your own stomach acid. NSAIDs strip that shield away. The mucosa becomes vulnerable to acid. Now, the acid starts eating into the stomach wall, creating tiny raw sores and exposed vessels. When you combine these drugs, Warfarin and Ibuprofen, which is an NSAID, you aren't just adding risks. You're multiplying them. It's a two-front war. The NSAID creates the wound. NSAIDs strip the stomach of its prostaglandin-mediated mucosal protection. Erosions form. The combination prevents the fix. Warfarin has already blunted the coagulation cascade. Factors 2, 7, 9, and 10 are functionally impaired. Secondary hemostasis is slow. Now the NSAID also suppresses TXA2, causing a drop in platelet aggregation. The primary platelet plug forms poorly or incompletely. Both lines of defense are compromised simultaneously. A tiny erosion that a healthy person would clot off in seconds becomes a flowing hemorrhage. Because NSAIDs also dull pain, the patient might not even feel the damage until they are vomiting blood or collapsing from blood loss. This interaction is a reminder that even a stable patient is often just one pill away from a crisis. In our opening story, the patient's labs were perfect, but that stability was a fragile balance. Because warfarin is a narrow-margin drug, the gap between preventing a stroke and causing a bleed is incredibly narrow. Because the body is so sensitive to this medication, the patient is always walking a pharmacological tightrope. When they add an NSAID, they aren't just adding a side effect, they are shaking the rope. Now, you might be thinking, okay, so doctors just tell patients not to take NSAIDs with warfarin. Problem solved. But that's exactly where it breaks down in reality. NSAIDs are over-the-counter. Patients don't always connect ibuprofen for knee pain with my blood thinner. They don't report it. They don't think it matters. And the bleeding can develop over days, not immediately. So the link isn't obvious to them. This is why understanding the mechanism matters. Not just for exams, but for communication. When you can explain to a patient, here's exactly why ibuprofen is dangerous for you, in plain terms. Not just it interacts, they're far more likely to take it seriously. Understanding the mechanism turns a dry warning into a life-saving conversation. When a patient understands the why, they don't just follow a rule, they protect their own life. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.